All right, we're going to go ahead and get officially started. Again, good evening. My name is Tim Gibbs. I'm the director and principal investigator for Delaware Health Force. Delaware Health Force is a public-private partnership between the state of Delaware and the Delaware Academy of Medicine, Delaware Public Health Association. One of our programs is Delaware Mini Medical School. And this Spring North series is done in partnership with Christiana Care. For those of you who attended the last spring series, that was done in partnership with the Sussex County Health Coalition. Here's some links. Follow us on social. We are on LinkedIn, on Instagram, on Facebook, on Twitter, and obviously also on YouTube, which is where we're live broadcasting to this evening. About the program. The program was, the Academy DPHA was founded in 1930, and we've been running Delaware Mini Medical School continuously since 2009. We did run something like it for a while in the 1970s, but that was before my time, and it ended and we picked it back up again. These 2024 semesters are offered as a part of the Delaware Health Force Initiative of the Academy DPHA. They're supported by state and local fiscal recovery funds to the Department of Treasury and the state of Delaware. And you might go, well, why is ARPA funding this? For you who are students who are in middle, junior, high school, undergrad, grad school, we want to expose you to a whole bunch of different types of medicine and dentistry, and also types of providers, with hopes that somebody or some topic will really ignite your passion and seal your commitment to being in healthcare or dentistry. There are no grades or tests in this. This is somewhat unusual in that respect. This series is one of at least 3 series that will occur between now and the end of this year. Interested students can attend additional series as they are announced. As those of you who are at the South Series, and I know there are a number of you, as soon as you visit DelawareMiniMed.org, see that there's a new series announced, go ahead and sign up. There's no continuing medical education credit or CE for this. So if you're on here as a professional, this is merely for an entertainment and enjoyment purposes. There's no CME or CE. Participants who attend all 6 sessions live will receive a signed certificate of achievement. That's why we asked for your U.S. postal address. For those of you who attend less than all 6 sessions and don't do one makeup session, can get a self-signed certificate. Whoops, I just skipped ahead here. So why do we do this? Aside from wanting to encourage people to go into this fascinating, field of healthcare and dentistry and public health, we want to enhance health literacy in our community. We want to share career pathways with students to clarify how current clinicians, providers, and researchers got to where they are today. And that represents this evening's speaker, myself, and my co-host, Nicole Sabine, and the story of how we got to where we are today. And we want to encourage a dialogue between you, the students, and the instructors in a safe setting where personal medical issues are not the focus of the discussion, where you're not about to have a shot given, where you're not about to get a diagnosis, where you're not about to get a tooth filled. This is a safe space. Housekeeping tips. This is a Zoom webinar. Turn your camera off. You don't need it. It'll save bandwidth. We can see your names, but we cannot see you. You can see us. There are over 1,000 students registered for this class, and people continue to come in, pour in. So who knows, how many people will ultimately have. Please only use the Q&A feature to ask your questions. Nicole and I, as I said, will keep up on that through the series. Usually we say we're going to answer all the clinical questions. However, if we end up getting 1,000 people here, it's very unlikely that we're going to get through all of your questions. we apologize in advance for that. We'll try to pick those questions that are the most comprehensive. You do need to stay through the entire presentation to be counted as present, but you can leave when the Q&A part starts. However, as I said earlier, I recommend that you stay. Lots of good learning and fascinating discussion through the Q&A. So I said, turn your webcam off. The Zoom is acting wonky. There's the link, youtube.com/Delamed302. I can see that we're live broadcasting now. Make certain that you send an email to tgibbs@delamed.org if you're going to view through YouTube. That's the only way we'll know that you're watching. For everyone else, as I said, you used your link to log in. The system has logged you in. So there's a new thing since last year, Delaware Youth Medical Academy. Let me break it down for you. This is also online, by the way, at delawareminimed.org. If you attend 1 to 5 sessions, you get a self-signed certificate online. If you attend 6 sessions or 5 in a makeup session, you'll get a signed certificate sent to you at home. And you might say, well, what do I do with a certificate? For students, this can become a good tool to use along with college applications. If you're going to go for an internship or a summer experience, you can say, look, this demonstrates my interest. And then there are different levels that you can go to become a member of the Delaware Youth Medical Academy. The minimum level is you complete the series and then you indicate your interest. We'll communicate with you saying, yay, you attended all 6 or 5 plus a makeup, and we will invite you to write a short paper talking about your experience, their particular questions. We don't announce those in advance. And then you'll be accepted into the Youth Medical Academy, assuming the paper looks good and we can tell that it wasn't created by AI. So here's the spring semester. Runs from April the 10th through May the 15th. Our first session this evening is about rheumatology, joint inflammation. Do I have an autoimmune disease? Being presented by Dr. Verma. Then we go on to thoracic surgery, behavioral health, endocrine disorder, sports medicine, and finally skin cancer. So about this evening's instructor, Devanshu Verma, MD, MBA, practices rheumatology at Christiana Care in the Wilmington, Delaware campus at Wilmington Hospital, and in Newark, Delaware at the Stanton campus of Christiana Care in the Medical Arts Building number 2. Dr. Verma attended Windsor University School of Medicine for his medical degree and completed his residency at Temple University, where he was chief resident. He also attended the Ultrasound School of North America Rheumatologists. Last year, he completed a Master of Business Administration from the West Virginia John Chambers College of Business and Economics. He has also been a rheumatology fellow at the University of Pennsylvania and at Drexel University College of Medicine. This evening, Dr. Verma will talk about normal joint anatomy and how rheumatoid arthritis affects joints. Dr. Verma will go over the signs and symptoms of joint inflammation and how rheumatoid arthritis can be diagnosed. I will stop sharing and turn it over to our guest speaker for this evening, Dr. Verma.
Thank you so much, Tim. It's really a pleasure to be here. I want to say thank you to the Delaware Academy of Medicine and the DPHA for allowing this to happen. And I want to actually echo something that Tim said, and which I think was the most extremely important. And what Tim said, the word that Tim used specifically was ignite your passion. That's a very key word because igniting your passion is what drove you to be here. That passion is what allows you to go forward in life and sort of pursue the dreams and ambitions you have. So never stop having a dream and actually always pursue your passions. Today, we're going to be talking about joint inflammation. Do I have an autoimmune disease? We're going to learn about joint anatomy, the normal anatomy, how rheumatoid arthritis or inflammatory arthritis affects the joints. We'll go over all the signs and symptoms and how rheumatoid arthritis can be diagnosed. Understanding that we have a wide audience and there may be students, there may be patients, there may be public from all paths of life. I want to just touch upon, since this is the first lecture, we have the words here, MD, MBA, RUMSA. This is for ultrasound. But you may be wondering, medical school, how do I get there? And the 4 years of undergrad first and 4 years of medical school, that's followed by 3 years of residency. And for rheumatology, 2 additional years of fellowship. And you can think of it as sort of like medical school is sort of like high school where you really go over a breadth of all topics, regardless of whether you're interested or not. And that gives you a taste of everything. After that, you can decide to focus on one particular area to go to college for. And that's sort of like residency. So residency, there's internal medicine, which is where rheumatology comes in. There's surgery, there's psychiatry. That falls under the residency category. And that can be anywhere from 2 years to 5 years. And then after college, you can sort of see if you really like an area, you can choose to go to do your master's or your PhD. That's sort of what a fellowship is. So rheumatology falls under the umbrella of an internal medicine first, and then rheumatology specifically is a 2-year course. So from beginning to end, you never think about the time, you just go ahead and do it. But from beginning to end, in total, if you're looking at after high school, there's 4 years of undergrad, 4 years of medical school, 3 years of internal medicine residency, and 2 years of rheumatology fellowship. Absolutely worth it. I would do it all over again. Not a second thought. Not a second thought. So disclosures, I have none. There's no conflicts of interest. I have not reimbursed, and all opinions are my own. I want to start with this. I appreciate the hard work of DM, DPHA, and of course, Christiana Care Health System, where I currently work. And it's a privilege to work with amazing people. And I want to just say this out loud. I think it's important to start with the mission and our goals. We serve our neighbors with respect, as respectful, expert, and caring partners in their health. We do this by creating innovative, effective, affordable, and equitable systems of care that our neighbors value. So I see everyone here as my neighbor, and I hope we have a strong journey together. So starting on a real case, a 64-year-old pleasant gentleman says that he has increasing pain in both knees. He asks if he has rheumatoid arthritis. First, let's define the terms. You may hear the word arth and itis all the time, but what do they really mean? Arth means joint. So if you've ever heard the stem arth, A-R-T-H, that's referring to joint. If you add the suffix itis, so I-T-I-S, that means inflammation. And it could be inflammation of any type. If you combine these two words, you get arthritis. Strictly speaking, inflammation of the joint. You may hear the words autoimmune disease. What does that mean? Auto and immune. So auto can be a prefix. That means self. So we have here a mirror, and you can see a mirror of the hand. That means self. Immune means your immune system. So when you add the two words together, you get an autoimmune disease, where the immune system, which normally is there to fight infections and things that don't belong, also to help heal and repair, instead of sort of attacking things that don't belong, when it's attacking yourself, that's called autoimmune disease. Osteo and rheumatoid. What does the word osteo mean? Osteo means bone. So anytime you see the word osteoarthritis, osteoporosis, osteo meaning bone. Rheumatoid, loosely speaking, is related to the immune system. You can say inflammatory. What are the two main types of arthritis? So again, arthritis meaning inflammation of the joint, but not everything is inflammatory. So the first bucket, you can sort of divide this into two broad categories. The first category is the one you see on your left, which is inflammatory, where it's related to an overactive immune system. The second category, broad bucket, you can see over on your, I guess, left is inflammatory and right is non-inflammatory, which is not exactly wear and tear. There's more research that says it's more than just that. There may be a good component of both. But just for the purpose of this, to keep it simple, inflammatory meaning an active immune system. And I should correct myself. It's not exactly an overactive, but an active immune system. And immune system and inflammation is not a bad thing. I want to clarify a misconception is that a lot of people think when you have inflammation, it's a bad thing, but you wouldn't be alive without our immune system. It's from the moment we're born, we're always protecting ourselves from infections. And the inflammation is just the way that the immune system works. So the immune system is active, it works through inflammation. And we want that. We want that to be able to protect ourselves. What we don't want is to be attacking ourselves, and that's the autoimmune part. Non-inflammatory is where it's more mechanical, fall, fractures, trauma, anything that is not triggered or driven by an active slash in an overactive immune system. So just remember these two words. If you ever have any joint symptoms, the first step of any primary care, rheumatology, anyone you see or ask, is it an inflammatory type or a non-inflammatory type? So how do you know? That is a very important question. How do you know? Is there ways to tell? So their symptoms are usually sufficient and for the most part very helpful. And you can divide based on stiffness, swelling, and range of motion. Using those three main things, you can have an idea of which bucket you fall into. To form the first part, we'll talk about an AM here means morning. So for morning stiffness, if you think you have, or if you have an inflammatory type of arthritis where the immune system is active, the stiffness in the morning is usually more than an hour. So, and loosely speaking, we can say more than 60 minutes, versus if it's non-inflammatory, it's usually less than 30 minutes. What about swelling? If you have an inflammatory type of arthritis, usually you have swelling of multiple joints, as opposed to non-inflammatory, it is usually without swelling. Not always true. For example, if you have knee osteoarthritis, you will get some water, but not necessarily because of an active immune system attack. So swelling, generally speaking, multiple joints are swollen, small, large, medium. That suggests inflammatory versus none. Range of motion is what ROM means. And here you can see that because of the stiffness or swelling, you have limited range of motion in inflammatory arthritis versus a good range of motion for the most part with non-inflammatory. Not always true in late stages. Yes, you can have a hard time bending, but in the purpose of this, if you have stiffness and swelling, usually it's hard to make a fist or get out of bed. And that's what supports the inflammatory arthritis. What about three additional things? Beyond that, we have activity, rest, and steroids or corticosteroids or glucocorticoids. So how do we tell if activity is inflammatory or non-inflammatory? If your symptoms improve with activity, it might sound counterintuitive. If you have joint pain, shouldn't moving it make it worse? That's for the non-inflammatory type. So if it's a non-inflammatory, if it's more of like the osteoarthritis or sort of wear and tear, loosely speaking, you feel worse with activity but you may feel better. And that means your stiffness improves, and that supports inflammatory, or if your pain stiffness sort of gets better with rest, that supports the osteo non-inflammatory type. So that's the second part. You feel worse with rest, inflammatory, and better with non-inflammatory. And the last part I mentioned here, if you're on like dopamedrol or if you're on medrol or prednisone and you feel better, that really can't tell because that sort of affects both. And it's not exactly a diagnostic step in any way. And you really can't tell based on that alone. Supportive, but not very specific. So to put in a different way, if you think you or someone, and you're like, hey, how do I know if this is inflammatory or not? What are three easy questions to ask? Rephrase in a different way. The first question is, how long does it take to loosen your joints in the morning? This might be something your family doctor or someone you see in the clinic may ask you. And that's a first question is very helpful because if it's more than 60 minutes, it supports the inflammatory type. If it's less than 30 minutes, generally speaking, non-inflammatory. The second question is, do you have swelling of any joints? If you have swelling of multiple joints all over your hands, your feet, your knees, elbows, shoulders, then that suggests an inflammatory type. If it's not, then you say non-inflammatory is more likely. And lastly, do you feel better with activity or worse with activity? If you feel better with activity, you can say it's the inflammatory type. If you feel worse with activity, maybe it is the the non-inflammatory osteoarthritis type. So those three questions are easy first, and you can ask them to anybody who says to have joint pain. How long does it take to loosen your joints? Do you have swelling? And is it better or worse with activity? So the next step is to sort of find what is the most common type, what the most common disease in each category. So in the inflammatory category, it's the rheumatoid arthritis. In the non-inflammatory category, it's osteoarthritis. And there's a whole list of both. But for the interest of our introductory talk, I'm going to limit it to these main types. And I'm going to put rheumatoid arthritis as sort of the classic inflammatory arthritis and osteoarthritis as the classic non-inflammatory arthritis. So when you're looking at how do you diagnose the inflammatory arthritis, specifically the rheumatoid type, we don't really have a good diagnostic criteria, but we have many, many classification criteria for for rheumatoid arthritis. And this is one example. American College of Rheumatology is excellent resource for anyone interested in rheumatology. This can be by moment. B is serology, and I'll go over that, acute phase reactants and duration of symptoms. So I'm highlighting here two main things because this is what's going to come up over and over again. Serology, and B is, as the C is acute phase reactants. So coming back to basics, serology. What does sero mean? Sero means blood, serum, serum or blood. Blood is made of your red blood cells, and the serum, which is the plasma, multiple other types. So anything sero as a prefix meaning referring to blood. Ology or ology usually means study of. So serology meaning basically blood test. So if anyone asks you, what were your serologies like? You're basically asking them, what were your blood tests like? Antibody. Where am I getting antibody from? Because remember, one of the criteria was serologies or antibodies. So anti means against, body means, in this case, protein. So these are proteins made by the immune cells that are basically mirror images or molded as mirror images of what the immune cells saw. Now, you and I can see, we have sort of eyes, we look at the visual light, but the immune cell doesn't have that light spectrum. They don't really have eyes. So they feel quite literally, you can say tentacles if you like, and the mirror image, a mold of the protein they saw, that gets fixed as the tip end of an immunoglobulin, immuno meaning immune system, globulin meaning protein. So these antibodies are mirror images of anything the immune system saw that perhaps didn't belong. So the common serologies, again, the common blood test or the common antibodies, the two, and this is not all of them. There's an extremely long list, but the two most common ones that are checked in clinical practice is number one, a rheumatoid factor antibody, and number two, an anti-CCP antibody, cyclic citrullinated peptide antibody. So this is just there's many different types. This is it looks like a Y shape. Not to go into immunology, but the tips of these Y-shaped proteins are what the sort of the receptors or the mirror images that sort of recognize what it is. And to give you an analogy of what to think of it like if you go to a police station or you go into a crime scene or you have like a home alarm system that has a camera, and if you spot someone in your home who shouldn't be there, you'll have a picture in your surveillance camera or something, and you can have that picture, take it to the police station, say this is a person who was there and that person didn't belong. And what the police station or someone will do, they'll take that picture and sort of make photocopies and circulate them all over the area so that if anyone else sees them, they can recognize that person and bring them in. That picture or that photocopy or that circulating image, that's the antibody. So it just takes one snapshot, but you can replicate that snapshot and distribute it everywhere, which is why the antibody does not mean you have active disease per se, but it means that you've been encountered or you've seen that something. Almost like you, if you see someone's face, you're going to remember that face, even if you never see them again. Immune system's the same. Even though you've had a single encounter, maybe it's your first infection you've never seen before, but you'll remember that for the rest of your life, or as long as you have the antibodies, which may be decades. And the next time you have that similar exposure to the same infection, you may not even feel it because you have a memory that's saved in the form of a protein called antibody, which will sort of be circulating along your immune system. And when the time comes, it'll be ready. So are you born with these antibodies? You know, some people may be asking, well, if I have these antibodies, if I have, for example, if you go to, for whatever reason, you had your blood test for these two things, if one of these two is positive, were you born with them? The answer lies in your immune system. And to understand that, we should divide and learn about the types of immunity. So type one and two broad categories. First is the innate immunity. This is what you're born with. These are the natural defenses that from the moment you're born, you didn't have to be exposed to something to learn it. You have bacteria all around us. We have spores and we have viruses all around us, but our immune system sort of has these built-in gene-encoded defenses, which could be something as simple as your skin. You know, it's a barrier. It could be something as simple as your tears. To have a lot of proteins that help protect you against a lot of dust and floating things. So we have these in the red circle are sort of your things you're encoded with. The adaptive or humoral response, That's the second type, or the humoral immunity or adaptive immunity. That's not what you're born with. This is something you learn over time. That's your B and T cells and more. But this is sort of the two broad categories. So if anyone tells you antibodies, are you when you're checking for antibodies, you're checking your blood for a lot of these blood tests. Usually you're checking for autoimmune diseases. So when you hear the word auto-inflammatory diseases and autoimmune diseases, they're not the same thing. Autoinflammatory diseases are issues related to the innate immune system, stuff that is sort of almost like these cells, the neutrophils, what they're programmed. If you see something, they should clear it. Once the clearance is gone, they should stop. But if there's a defect in the receptor or the gene, they start, but they don't stop. And it's a cycle of inflammation that doesn't stop. Fevers, rashes, ulcers, things that are usually common in kids, but also later in life. Versus autoimmune diseases take time and exposure, but it's not something you have to be exposed to. There's a combination of things. So the analogy of an autoimmune disease is your roommate got into a car accident requiring plastic surgery because of facial burns. And then you call the police when they enter the house because you think they're an intruder. Now, they were at deep inside, they're still your roommate. They've been to the house, they have the key, but because of the accident or the burn, the surgery, you don't recognize them that way. So it's the same person inside, but on the outside, they look a little different. So to you, they look like foreign. So now you see that picture, and to you, that's activating your immune or defenses. And that's the same thing what the immune system does. So to answer the question a little bit more specific, are you born with these antibodies? You're born with these blood tests that come back abnormal if you have joint pain. It's due to post-translational modifications triggered by triggering autoantibody production. So these post-translational modifications, if this is going overhead, it's fine, but just for our students out there, things that these are the proteins A's which you're born with, but due to things that are stressed, the neutrophils, the bacteria, and infections, it activates this PAD enzyme, which converts this amino acids to citrulline, and that is what we call citrullination. That is what the body has not been exposed to. So this is sort of like your roommate, they're fine, and now they have the surgery and they look different, and you're like, who are you? The immune system does the same thing, is like, who are you? And therefore you have a rheumatoid or this anti-CCP antibody. This is a different sort of a citrullination or carbamylation. We have a different smoking, kidney disease, and inflammation in different areas, which is why we say smoking has a risk factor for rheumatoid arthritis because of the potential to activate some of these proteins that sort of change your protein that you're born with to make them look different and therefore trigger an immune response. There's a lot of these antibodies, but the antibodies are sort of, and the symptoms of rheumatoid arthritis are sort of like there's follow a spectrum. So not everyone sort of has no disease and has disease. It's not such black and white. There's often a very long spectrum, starting all the way to your left to being healthy, but at risk, where you have no symptoms whatsoever. You may have some genetic susceptibility, some HLA changes. You may have some childhood infections or things that sort of put you at risk, but from all practical purposes, you're totally fine. You feel fine. There's really nothing happening. And then you have the pre-symptomatic phase. This is where you may be, like, for example, exposed to your new infections, your microbiome in the nose or your gut, some lifestyle environmental factors, smoking, diet, contraceptive, and many different phases. And then we have this expansion. So that thing becomes more and more active. And then you transition to become symptomatic. So this is the autoimmunity sort of beginning phases. And then it's not until later where you sort of peak, where you reach the tip of the iceberg, where you present with symptoms to your family doctor, right? Or to your primary care. You're looking at that sort of symptom of swelling, stiffness, limited range of motion. I hurt, I have a hard time doing things. I'm so swollen, I can't make a fist. That's the tip, but you've had a long sort of period of preclinical disease before that got there. So when you check for your blood tests and they're positive, does that mean you have active disease? And I want to repeat that question because do positive tests mean active disease? It sounds like a simple question, but it's in fact one that comes up all the time in clinical practice because having a positive blood test doesn't really mean you have symptoms. In fact, you can do your blood test for this and in research and whatnot and see that you may have these positive, but you may not actually have disease for years, decades, or not at all. So this was a study done time and years on your bottom and then percentage of positive samples. You see the CCP is the one in this maroon color square. And you can see how as far back as 14 years. So that means you can have a positive blood test for up to, a decade, decade and a half before you develop any symptoms. This is a different way of looking at the rheumatoid factor here. This is a different antibody. You can see how it goes back 20 years and the positive samples. So of course, at the time of diagnosis, you look back and you say, well, how many of these patients had this positive antibody as a part of the study and then didn't have any symptoms? And you can see it goes back years and decades. So having a positive test does not mean you have the disease. It just means that a positive test. But this is what becomes more relevant. So likelihood ratio is the probability of a positive test in someone with the disease, in this case, rheumatoid arthritis, and probability of a positive test without the disease in someone who does not have rheumatoid arthritis. And you can put the probability as if it's the higher the number, the more the probability of someone truly with the disease of likelihood, and the probability, if it's less than one, approaching zero, the lower the probability of doing so. And the general rule, we say 2, 5, and 10. 10 is like 45%, 5 is 30%, 15. But generally speaking, the higher the likelihood ratio, the greater the probability of the disease in the future. So this is the rheumatoid arthritis likelihood ratio based on its serologies. And to put it in sort of a different arrow, you can see that the more positive antibody you have, if both are positive, that's a much higher likelihood ratio compared to if only one is positive. This is a very convoluted picture, so I've simplified it in this diagram. So in here you can see on the top is a rheumatoid factor antibody. This is on your left an anti-CCP antibody. The two most common tests. On the green is if both of them are negative. So the likelihood ratio for rheumatoid arthritis, if you have both negative rheumatoid factor and a CCP, is 0.3, which if you go back to the ratio is coming right about here. It's like a decreased probability of having it in simple terms. The opposite is quite dramatic. So if you have both rheumatoid factor and anti-CCP positive, especially at high titers, your likelihood ratio is above 40. That's a pretty high probability of doing so. But again, does not mean you have active disease, but the probability, maybe yours. It's sort of in the middle. Well, if you have only rheumatoid factor positive, it's slightly higher. If it's CCP, it's slightly higher than that. It's a little bit more specific. But generally, if you had to, choose something, to remember something, if both are positive, that's the highest. If both are negative, it's somewhat helpful. It doesn't rule it out, but it's helpful. So to ask the question a different way, if you're someone who is here, if I have negative rheumatoid arthritis blood test, does that mean I don't have rheumatoid arthritis? If I have both of blood tests positive, does that mean I have rheumatoid arthritis? All right. This is where the answer is no. So positive rheumatoid factor or CCP, or just blood test in general, period, for rheumatoid arthritis does not mean you have rheumatoid arthritis. So if you're someone who's a primary care and you're ordering blood tests, unless you have a good pre-test probability, unless you have symptoms, the blood test may not sway you one over the other. And the reason is if you look at this chart I showed you before of high positive rheumatoid factor or the other antibody CCP gives you a score of 3. But the diagnosis sort of requires a score of 6 or greater. So just alone having this, it's not going to make that 6 number in strictly speaking. But the opposite is also true. If you have multiple joints that are swollen for longer than 6 weeks, you don't need the antibodies at all, right? A lot of times you actually can make a diagnosis of rheumatoid arthritis without any blood test. So inflammatory arthritis based on swelling, stiffness, range of motion, if you have multiple joints, large and small, swollen for longer than 6 weeks, and we say 6 weeks because that's sort of the cutoff. You can have reactive arthritis and some of the short-lived, which are not actually autoimmune, but more of an active, appropriate immune response. But if it's persistent, if it's going beyond what we expected for a normal response, then you say, okay, this is a chronic active inflammatory or rheumatoid arthritis. So which questions do you ask? How long does it take to loosen your joints in the morning? Do you have swelling of any joints? And is it better with activity or worse with activity? If it's more than an hour of stiffness, multiple joints that are swollen, and you're better with activity, it may be the rheumatoid arthritis. The other part was the ESR and CRP, right? So the ESR and CRP are the markers of inflammation, so to speak. Again, I use the word inflammation because inflammation means an active immune system. So if you're using these markers of inflammation, they're not markers of autoimmune disease. They're not markers of anything. They're not markers of rheumatoid arthritis. They're markers of inflammation, meaning an active immune response. And your immune response can be an appropriately active immune response. If you have an infection, your inflammation level will be high. Not in a bad way, it's appropriate. You want it to be. So if you measure your erythrocyte sedimentation rate, erythro meaning red, cyte meaning cell, sediment meaning how fast things fall. Rate is how fast it falls. So erythrocyte sedimentation rate, quite literally, crudely, is you put your blood in a test tube and you quite see how fast it falls. Because blood is made of plasma and red blood cells, you'll see them sediment out, where the plasma will layer at the bottom. And crudely speaking, the more inflammation, the faster the rate of that sedimentation. So it's quite literally measured in millimeters per hour. So on your blood reports, if you are looking at someone's report and you see the ESR, the erythrocyte sedimentation rate, is 100, that's pretty high. That's higher. What is a normal rate? It really varies. In general, 20 to 40 is considered normal, and it changes based on age. So for men, it's about age divided by 2. For females, age plus 10 divided by 2. If you're not sure, just divide your age by 2, and that's a good ballpark. And I say that because as the older you get, the sort of the normal changes. So if you're someone who is 80, your normal ESR value is about 40, but the lab test will show you a universal cutoff of 20. So just because your blood tests are marked as high doesn't actually mean high. So you have to interpret the numbers and sort of gauge out for yourself. So the higher the number, the more the inflammation. Now, it's not specific. That's important. It's not specific to rheumatoid arthritis. This can be high and you fall, you have a cold, you got COVID, you had a fracture, you're recovering from pneumonia, you just had your vaccine 2 days ago. Your immune system will be active. So the ESR will be high and it changes day to day. This one takes a while to kick in. It takes several sort of days to weeks for this to level. The other inflammatory marker is the C-reactive protein. It's a protein that is sort of reactive in response to inflammation. Crudely speaking, it's shaped like a C, which is where the C comes in. So the CRP is a second marker of inflammation. This also is in response to inflammation. Therefore, it's measuring an active immune response. It is not measuring autoimmunity. It is not measuring in sort of any sort of um, overactive sort of autoinflammatory thing. It is only measuring an active immune response, which may be an appropriate response. So it's important to do these tests only when you're otherwise stable. If you're sick, if you have infection or antibiotics, that's not the best time to check the inflammatory markers because they may be falsely elevated, right? It also goes by age and weight, which can also falsely raise them. So CRP is made by the liver. It's a protein made by the liver. And this is, not to go too detailed, but essentially a lot of different inflammatory triggers, infections, things that release these sort of interleukins that tell the liver, hey, let's give me some inflammation. And inflammation in the sense that this is the part of the immune system that does the effect. So these proteins will go out into and do their various effects normally to treat infections. So you have platelets that are activated, your immune white cells that are activated, the lining of the arteries are activated, the complement system is active. So they serve to activate the immune response to help us sort of fight infections. But targeted the wrong way, it can also target your own healthy proteins, hence the rheumatoid arthritis. So the joint, and we're talking about arthritis. We use the word arthritis all the time. What is it? What is the joint? What does it look like? Where are we with this, right? So this here, the top part is the bone. Both of these are bone. You can think of this as any joint. You can think of this knee, the hand, any joints coming together. In the middle, we have the cartilage. On the outer side here, we have highlighted in green is the joint capsule. On the outside with synovial lining in the middle. That's a keyword, synovial lining. Synovial lining. The blue is the bursa. Bursa is, think of this like a balloon bursa. Balloon that's a little bit, it has like sort of rolls off to help you not rub with friction against the edges. We have the muscle over here. We have the tendons. So again, what are the difference between tendons and ligaments? Ligaments connect bone to bone. Tendons connect muscle to bone. So we have the muscle that becomes the tendon and inserts into the bone. At the point where it inserts, we call that entheses. At the point, and that's an important word too, not for rheumatoid, but other things. So entheses, if you combine the word itis, enthesitis is seen in other types of autoimmune arthritis. And here we have a ligament connecting bone to bone. So muscles connecting your tendons, so tendons connect the muscle to bone. And the reason that's important is because if you have a weak capsule, your joint may be unstable, instability, and that can be improved with physical therapy, which is why we say if you strengthen your muscles and you have good muscle bulk, you will have stronger tendons, which are a part of the joint capsule. It makes everything tighter and more stable, which makes it less painful in the long run, right? So defining terms. Remember how I said synovial lining? Sino means synovial lining, which is a lining that lines the inside of the joint, and that's what makes your synovial fluid, the water inside the knee. You always have a little bit as lubricant, any joint. Itis meaning inflammation. So synovitis means inflammation of the synovial lining. Rheumatoid versus OA. So on this side we have normal, we have the bones, we have the cartilage in the middle, we have a normal synovial lining and a normal capsule on the outside. In the middle, we have the osteoarthritis, osteo meaning bone, right? Osteoarthritis. So here we have the sort of the wear and tear. I don't like saying that wear and tear too much. And I'm sure decades from now, you'll look back at this and think to ourselves, what were we thinking? But as of just to keep things simple, you see this synovial lining is normal, but the cartilage has been worn out or degenerative, hence the degeneration of the cartilage. We can say degenerative disc disease is a similar process. On the right here, we have the rheumatoid, where the cartilage relatively maybe maintained, but the thickening of the synovial lining, because that's where your immune response is active. That's where the inflammation is happening. And the cardinal signs of inflammation are warmth, redness, tenderness, pain, the whole swelling, which as you see here are signs of an active immune response in a joint. So how do you tell one from apart and where the different locations? You can tell by many different ways. Hands are actually very helpful. Hands are very helpful. So osteoarthritis versus rheumatoid, which is same as saying non-inflammatory versus inflammatory. In the blue are the joints where you expect to have non-inflammatory arthritis. In the red are where you expect to have inflammatory arthritis. And they can be an overlap, but generally speaking, this is very helpful if you're starting out. And in the blue and here, you're looking at the tips of your fingers. I won't go into the anatomy of it. It can be confusing, but in general, you can think of your knuckles. That's a classic area for rheumatoid arthritis, and osteoarthritis does not happen there. Your wrist is a rheumatoid arthritis place, and your osteo does not usually happen there, with the exception of the base of the thumb. This is a very common area for the wear and tear, and the tips of the fingers, the joints right below the nails, that's the DIP joints, that's where you have osteoarthritis. So wear and tear, tips of the fingers, osteoarthritis, rheumatoid arthritis, knuckles and wrist, generally speaking. So that's where your distribution can be helpful, supportive. Now, you could say it's not just for OA and RA. So reading the hands, if you just come into the clinic, and this is why we say in rheumatology, physical exam is very helpful, sometimes much more helpful than anything else combined, is just by looking at the hands, you can have a very good idea of, and just by looking first glance, you can see if someone has rheumatoid, osteo, psoriatic, pseudogout, gout, reactive arthritis, diabetic neuropathy. So here I'll just focus on the hands. Primary osteoarthritis, here you can see the tips of the fingers involved along with the base of the thumb. In rheumatoid, you can see the knuckles and the middle parts of the wrist. In psoriatic arthritis, it's also the tips, but also the whole finger. So you can see like the entire sausage-like digit is swollen. In pseudogout, you have narrowing of the knuckles, and then in gout, it's more of just like the wrist and scattered areas. The big toe is the most common one. So how do you tell them on an X-ray? This is an X-ray of a knee, for example. This is the top bone, the bottom bone. This is the kneecap in the middle, and it's empty space, but it's not actually empty space. The X-ray just only see bone and they go through the cartilage. So this empty space is not actually empty. The bones are not floating. There's a cartilage there, and there's a capsule and tendons and muscles, but the X-rays are really good at looking at bone. So this is the normal looking knee X-ray. In osteoarthritis, you see the narrowing, right? You see the narrowing. So we see the osteophyte. Again, you see the word osteo meaning bone. Phyte means growth. So a growth of bone at the edge, you see that sharp edge, and then you have the reduced joint space, so the joint space narrowing, but it's asymmetric. Notice how the outer half, this is your fibula, you notice the outer half still has a good joint space, but the inside is narrower. That may be because of some angle and more stress is on this side, but osteoarthritis is, in this case, there's more stress or wear and tear on the middle half than the outer half. Versus rheumatoid is more symmetric. Now, this could also be osteoarthritis too, yeah, fine. But the point being is that it's more of, it's not a wear and tear process, it's more of an active inflammation, which does not favor one half over the other. It should be both. That's why it's symmetric narrowing versus asymmetric. It's a clue. It's not universal, but it's a good clue to have. So normal hand X-ray looks like this. So it's almost like my hand is like here, and you put it on the screen. And then if you can see my cursor, this is your wrist bone. Yeah, your wrist is made of multiple smaller joints. This is your knuckles. So over here, this is my mouse. This Here in the middle are these middle joints, and then here at the tip are literally the tips. So this is what a normal hand X-ray looks like. This is just for a relative comparison because as we go into rheumatoid arthritis, you can see the difference. On the right, we have a picture of someone who has swollen, again, knuckles. And you notice here how there's quite marked narrowing of the MCP joint, along with some erosions. Erosions meaning the bone themselves have eroded away. The inflammation is the lining of the joint. Remember the lining of the joint. But if you have inflammation there long enough, after weeks and months and sometimes years, that inflammation will dig deeper into the bones because of all that inflammatory acidic environment. It'll erode into the bone and it'll cause this little pits to come up. So this is where the erosions over long term can happen. And that's what we see over the MCPs. And this is what an X-ray. Now, X-ray won't show you swelling, but here you can see some swelling over the knuckles. This is what, now you don't see this anymore. And I don't think anyone here has to be worried about this. This is a late stage of rheumatoid arthritis. This is what used to be shown in medical school decades ago, and it was a predominant because if you don't control it and you leave it there for months, years, decades, this is really where it comes into. That's when it leads to these advanced changes of quite prominent subluxations with these erosions. Erosions meaning the erosions have really eroded and eaten away at the bone, so the knuckles, and you have these deviations of the hands, and you have these almost fusion of the wrist, where the all that inflammation over time. It's almost like, think of it like butter. If you have two sticks of butter when they're cold and take them out of the fridge, they're very smooth, they're slide right, they're very lubricant, which is how the joints are. They really slide, they help prevent any friction. And if you have inflammation between those point of contact between those two butter sticks, think of it like a hot butter knife. You're putting it right through and it's going to melt the edges. So you, at the time of inflammation, you probably will not have much limitation because you're still, the heat, the melting is still allowing it to move. But if you have repeated flares of inflammation, more and more heat over time, it's going to melt, cool down, melt, cool down. That's going to put the sticks together. So instead of being two butter sticks, they're going to be one stuck together. And that's what happens in rheumatoid arthritis over time. If you have a joint, it becomes fused and we can erode it. This is the osteoarthritis hand X-ray. So in here, you see that the knuckles are normal appearing, right? There's not narrow, there's no erosions, but look at the tips, the tips. So this is on the right side, you see the osteophyte. So these nodules or nodes, they're nodules, but they're not skin nodules. Yes, they look on the skin, but they're not like lipomas. They're not some little skin or muscle. They're actually coming from bone. They're just osteophytes. They're growth of bone, and the body has a good protective mechanism. So if you, for example, if you're going to the gym every day, you're working out your muscles, you're putting stress on them, the muscles grow. They get bigger. That's how you build your muscle. Same process. If you have a cut on your skin over time, the immune system, your body's going to heal and repair. So over time, you heal it and it scars as a part of putting more and making it stronger. Bones are very similar. If you put stress on the bones, they will grow. They will reactively try to protect themselves by adding more calcium, which means growth. So osteo meaning bone, phyte meaning growth. You'll have osteophytes at these DIP joints. And here you can see the narrowing between, so the cartilage space between them is less. Plus you see these nodules over in the X-ray, which on someone's hand will look like this. You can see them here. You can see them at the base of the thumb, the squaring, and they can be these growths of bone can be anywhere where you have the stress. This is an overlap. I put this here just for our purposes. I don't want to confuse anybody, but there is an overlap between inflammatory and non-inflammatory osteoarthritis, where you can see the same narrowing, but with some of this central erosions. So there's gypsum, but just know that there's a potential for overlap and it can happen. So how can ultrasound help? This is sort of, I want to put this out there to spark some curiosity here. We can see that the probes here, these probes come in different shapes and sizes, and they help us look deeper than the skin. They help us, when you're looking at your hand, you can see if there's swelling on the inside, if the bones are big, if there's any inflammation or synovitis. So I want to point the word synovitis because that's a hallmark feature of inflammation. That's when you go to a rheumatologist or a family doctor, you're looking and they're pressing on the joint. You're pressing on it because you want to feel the edges of the bone. If you can feel the edges of the bone, that's pretty good. That means the bones are close, there's not much swelling there. But if you cannot feel the edge of the bone, that tells you there's a clue that may be swelling. But the ultrasound helps you see deeper, and you can tell if there is synovitis, inflammation of the lining of the joint, and you can grade it. This is grade 1, meaning you have the different bone. And imagine an imaginary line between this point and that point. If you have inflammation or the synovial thickening, you will see it bulge up. Grade 2 is if it bulges up beyond that imaginary line. Grade 3 is sort of when it's bulging quite far back, and you can see the Doppler is just if you put your signal and the ultrasound shows you how much of a vascularity or how much blood is flowing through there. If there's an increased blood flow in the area, you can say, well, there may be inflammation. Because a part of inflammation is recruiting more help. And it's almost like if you have an area of an injury, if you have a bridge collapse or if you have a road collapse, you're going to want to recruit more help. So you're going to need to build more pathways, more roads for help to get there. So if you have more blood flow, it's a sign that the body's in there is asking for more recruiting for the help. So here is this swelling. So in the bottom, this white line, that's your bone edge. This little black area here and here, that's the lining of the joint. But because of the inflammation, it's gotten bigger, it's gotten swollen. So wrist is something similar. So in a wrist, you can put your probe right over here. And in this example at the bottom, this is your, I'm not going to go names, but the bones of the wrist. And here you see this black here and here, these bulging, ballooning parts. That's where the lining of the joint is pushing up because it's swollen, because it's inflamed. This is the wrist looking at the side view. So this is on the top right. You can see how the lining here is swollen and thick. These are the tendons, and you can see how much swelling there is. This allows you to see anything that you couldn't readily see on hands, and it's much more specific. You can quantify it, you can monitor it, and see if you're getting better. And clearly you can see if there's erosions because the bones will be eroded underneath it. This is an elbow, so this is on your elbow on the back over here on either way, and you can see clearly in this case, you see the fossa, or sort of like where the elbow opens into, and all this black is an effusion, water. I say water loosely. I mean, when your synovitis, meaning when your synovium is inflamed, and the job of the synovial lining, in part, multiple jobs, but one of them is to keep the synovial fluid, keep it lubricated. If it's inflamed, it's going to make more, so you have water. And that's in something of an important point. You can have swelling of the joint, doesn't always mean it's water in the joint or an effusion in the joint. Sometimes it's just thickening of it, which can look like it. So this is water and effusion in the elbow, which can be readily seen, and you can drain it. This is a knee. Knees are very common because this sometimes is a very, overlap, and a lot of people have knee pain. Not all the time is it inflammatory. So if you look under the ultrasound, you can see the swollen synovial thickening of the lining of the joint. You can see the black sort of effusion or water inside the knee. And you can see here that there's also a Doppler. So this gives you a clue of how much, if there's thickening, this is a side view of the same knee. You can see how can be the synovial can be boggy and really thickened, that supports inflammation. If it was non-inflammatory, you would not have the thickening. It would just be a thin layer and just water alone without that thickening part. This is an MRI of the same thing. You can see the bone, and here the white stuff is the effusion, and you can see the thickening of the lining that goes all the way, up in the knee. This, incidentally, plaque is just a remnant. I won't go into it, but just that's one of the mechanical causes. But knowing that MRIs, CTs are not really done, but usually X-rays and ultrasounds are good enough. Actually, your physical exam is good enough for the rheumatoid arthritis. Now, ultrasound can also be used to drain. That's helpful because if you have suspicion for inflammatory versus non-inflammatory, in addition to your physical exam, in addition to your imaging, in addition to your blood test, you can drain it. Because if your synovial lining is inflamed, you can just drain that fluid and see if there's inflammation there, quite literally. This is an ultrasound of the knee, and you can see the white is sort of the water. This is the needle coming in. This is what the fluid looks like. It's dark, it's yellow, it's cloudy. And on the microscope, you see crystals. You see gout. So this was inflammatory arthritis, but not rheumatoid. This was gouty arthritis. So this is a clue. If you're draining a knee or any joint, really, how do you tell if it's inflammatory or non-inflammatory? These are some of the sort of different phases. So normal inflammatory versus a fully inflammatory, you can see based off of color, thickening, and then the immune cells that are there. That's the WBC. It's the white blood cell count. In general, because inflammation is related to the immune system and immune cells, the more immune cells you have, the more white blood cells you have, the more suspicious of inflammatory type. The thicker, the darker the yellow the color, the more likely there's immune cells there, and that's more inflammatory. And the thicker it is, generally speaking, you want to be. It's a mixed bag, but generally speaking, viscosity can be very variable. And here we're going to look at just as a picture. You can see how normal fluid, this is quite extreme, but it's very clear. Non-inflammatory is light yellow. Inflammatories are darker, cloudy yellow. Septic is extreme. It's the most inflammatory we can probably will go up to, and that's where you can see the pus coming into it and bleeding, which you just see blood on there. So looking at this on the microscope and staying in the lab and seeing how many white blood cells you have. Generally speaking, if it's more than 2,000, it's suspicious. Less than 2,000 is reassuring. But the more likely. But you can have a normal lab. Inflammatory does not differentiate infectious from autoimmune. So if you have a high white blood cell count, and if it's one joint or very small number, you should always rule out infection. Um, and alternate causes of inflammation. So gout is also inflammatory. This is what the crystals will look like. Again, with you drain whatever, whether it's the wrist, the knee, the ankle. If you look under the microscope and you see crystals, you see these yellow, blue, birefringent, needle-shaped crystals or rhomboid shape here, these don't belong, right? So these crystals, when we have uric acid, we make it all the time. It's a part of our metabolism. If there's a decrease in filtration rate, if the kidneys are not filtering as quickly for whether it be many different causes, that increases the serum sort of concentration of uric acid where it's not filtered as well. And if it goes above a certain number, it's almost like water. Uric acid is quite literally like water where it just dissolves in the blood and it flows right away. But if you put water in the freezer, it crystallizes, or like water in the winter, rain becomes snow. So in uric acid, when the concentration is too high, the soluble becomes crystal, which gets stuck in the joints, in the acidic environments, in the toes, distally. So you have feet, ankle, whatnot, and that can go up further. But if you look under the microscope of the joint that's inflamed, so it's inflammatory, but you'll see crystals as opposed to the rheumatoid big picture, and you won't see them. So this is supportive of gout and different crystal arthritis. On the X-ray, you can see the erosion. So we have a narrowing of the joint. You see the swelling, but you see the erosion here. And that's a little bit different because the erosions on rheumatoid look a little bit different. Here we have like the rat bite sort of there where we have in here like the marginal erosion. So they're different. Now you can have pseudo rheumatoid arthritis, right? Pseudo defining it means like. So pseudoscience is like science. Pseudo rheumatoid is like rheumatoid, but not exactly. CPPD stands for calcium pyrophosphate deposition. So when someone says CPPD disease, they're talking about calcium pyrophosphate. Again, this is a crystal as well. So in this case, the CPPD on can mimic rheumatoid arthritis. And on X-rays, you'll see literally, in simple terms, calcium within the cartilage. Within the cartilage. That's important because you should not have calcium within the cartilage. So in this X-ray, you see the top and the bottom bone. You see the cartilage in the middle. And you can see here this white line, the straight white line, that's sort of not a part of the bone. It's within the bone, which is where the cartilage is. And that's the chondrocalcinosis. Chondro meaning cartilage, calcinosis meaning calcium deposits. And here's a hip X-ray. You can see the ball of the hip. This is the socket of the hip. This white line in the middle, that's chondrocalcinosis. That is inflammatory, right? If you should not have calcium depositing inside the cartilage. Your immune system is going to see those calcium phosphate crystals, and then the calcium pyrophosphate crystals are going to cause an immune response. The immune cells clearly see this as something that doesn't belong. They're going to react to it. But is that an autoimmune disease? Auto meaning self. Is it an autoimmune disease? The answer is no, because you're not attacking yourself. It is an inflammatory response. Your immune system is active, but not active against yourself. It's active against these calcium phosphate crystals. But on the outside, it'll look the same because inflammation is inflammation from regardless of the cause. So in here, you'll have a similar swelling, stiffness, decreased range of motion. And your clues may be one, normal blood test, and B, x-rays where you see the chondrocalcinosis. So in the hands, the clues in the hands here is that in rheumatoid, you see erosion of the knuckles. In chondrocalcinosis, you see narrowing of the knuckles with these hook-like osteophytes or hook-like bone spurs, very sharp edges, just one clue. And this is a wrist. You can see the calcium white line within the wrist cartilage. So this is how, if you do x-rays in someone who you think may have rheumatoid and you see this, well, oh, it's pseudo-rheumatoid, like rheumatoid arthritis, because of the pseudo-gout. And treatment is very different because this is not an autoimmune disease. You will not have antibodies against your own joints and proteins, but your body is just trying to clear these crystals that are getting stuck inside the joints. But their attempt at clearing them is what causes the inflammation, which causes joint pain, swelling, and stiffness, right? So if we come and circle back to this case, this is how we started off with, right? A 64-year-old peasant gentleman says he has increasing pain in both knees, rheumatoid arthritis, the symptoms improve physical therapy, and he was diagnosed with osteoarthritis based on pain, swelling, um, stiffness, and limited motion. Now, I want to plug in the last case. Pain is very non-specific. So when anyone tells you there's pain in my joints, pain sort of anywhere in the body, pain is a very good sign for the body to tell you. It's a very good feedback mechanism, but it's not very helpful diagnostically because it can be very non-inflammatory to very inflammatory, and they cannot tell. So we try not to use pain is helpful to localize and ask more specific questions and target our workup, but it's not very helpful to tell one from the other. And if you only have pain without any swelling, without any stiffness, without any limited range of motion, it's a good in terms of it's less supportive of the inflammatory type. And if the other imaging lab tests are normal, it's reassuring that it's less likely to develop into the rheumatoid type. So that's the summary for here. I know we went over a lot. Some of it may have been quick, but I hope this was helpful. And I'm happy. I'm sure there were questions as I was coming along. I'm sorry I wasn't able to see it, the question answer as I was presenting, but I'm happy to take questions that may have come, anything that is there. I'm going to stop sharing my screen. I'm going to open it up. Tim, you have the floor.
Yep, we have questions. All right, hold on for a second. Let me get myself organized here. All righty. Well, some of these questions came in, and now that I'm rereading, they don't quite have the same context as they did when you were speaking. Is hepatitis B also an inflammation problem that can contribute to other osteo or rheumatoid arthritis symptoms?
Totally. And reactive arthritis is reactive to any immune trigger, quite literally. So hepatitis B, Hep C, HIV, a lot of viruses and bacteria included, they will, as they trigger the immune response to clear the infection, that can sort of, in simple words, spill over into other areas. So it is very common to get not just rheumatoid, but other types of autoimmune diseases, other pathways of the immune system can become active. So it's a whole separate, in fact, it's a whole different chapter or category. It's very common to have hepatitis B and hepatitis C related, not just inflammatory arthritis, but just inflammatory organ involvement, so different autoimmune cases that are associated with um, not just hepatitis, but any virus, in fact.
All right, so what about poison ivy, bee stings, mosquito bites?
Absolutely. Great question. It's inflammatory. They are an activation of the immune response. But remember how I showed this slide about innate versus adaptive? Those are the things that you are born with. So that's your natural, like allergy and immunology. They deal with the autoinflammatory. That's an activate. So that is inflammatory. Absolutely. And that can sometimes mimic joint pain swelling, but that is not the usually you don't see arthritis, you can, but bee stings, contact allergies, medication allergies, seasonal allergies, they're all activated immune responses, but they're the innate immune responses, and that's an appropriate response. So generally, that's all immunology does. That's a great question because in the entire field, it's actually a fellowship. Allergy and immunology is a thing itself. That's all they do. So there's a commonly very big overlap in rheumatology and immunology and allergy, where you have these like hives and urticaria and this vasculitis, inflammation of blood vessels that is as a result of what would be hives. And I take that a step further. It's normal that if you have a bee sting or bee, whatever allergy response, it's normal to have that and it goes away. The problem is when it doesn't go away. And that's what you call autoinflammatory, where the immune system knows to trigger it, but there's some stops that it doesn't follow and it just keeps on rolling downhill, or it doesn't start when it should, right? So any part of that immune pathway, if there is a problem, that's what's going to give you that autoinflammatory response.
Gotcha. All righty. I believe that you answered this later in your presentation, but just in a nutshell, what does it mean to be diagnosed with seronegative uh, rheumatology?
I probably should have. So seronegative versus seropositive rheumatoid arthritis. So sero meaning blood, serum. Seropositive generally means either one of those two, either rheumatoid factor or CCP. If either one of those two are positive, you can say seropositive. If both of those are negative, you say seronegative. Now, the diagnosis of rheumatoid, as I said, is not based on blood tests. Blood tests only help support the diagnosis, but they don't make the diagnosis. So if you have swollen joints everywhere, you can't move, you're bedbound, you clearly have inflammation in the joints based on those three symptoms, and they've been going on for longer than 6 weeks, clearly inflammatory arthritis, and it fits in the distribution. It's looking like rheumatoid, it's talking like rheumatoid, but the blood tests are negative. Does that rule it out? No, you don't need the blood test because, and the reason I can explain that is because the body may have antibodies to many different parts of the proteins. These are just the two common commercially available ones. In the future, maybe 100 beyond our generation, beyond our lifetime, we may just do genetic testing on everybody. We may just see what you're at risk for and just do it. But as of now, there's a lot of research in different types of proteins and antibodies that are out there, and there's a whole panel of them. But when you test or go to any of the commercially available tests, the most common ones, the RF, the CCP, are being and the 14338, and there's more than that. Those are the ones. If they're positive, it's helpful. But if they're negative, and you have inflammation clearly on symptoms, it may just mean that it may be a different antibody, but we're just not checking for it. But we still say it's seronegative because the tests that we check for are negative. It doesn't mean that it's not there at all. It's not on the test we check for. So seronegative rheumatoid arthritis falls into that category. It's very much treated the same as rheumatoid arthritis as seropositive. But we just know that patients are dually positive at a high risk for more advanced disease and more aggressive disease. But for all practical purposes, the diagnosis is very much similar.
Right, right. Interesting.
Well, yeah,
So
there's
one of
a,
the questions
yeah.
that go ahead, Nicole.
I was like, there's a question we've had quite a few people type in. Can you have both osteo and rheumatoid arthritis at the same time? And if you can, how common is it and how do you treat it?
Absolutely. It's a great question because it is quite common. Osteoarthritis, there's more and more research as we speak over the years, and it's a function of multiple things. Age is one of them, but it doesn't preclude the active inflammation. So if you have, for example, the wear and tear type of arthritis, which may happen, like say you're whatever age you want to call it, and it's there in the background, and that's fine. That can be in the background. But then it's not, and that's the distribution will tell you that. You'll know if it's in the knees, you see the x-rays, you have joint replacement, it's fine. But if you have a different distribution that sort of comes up, and I didn't mention this, but the epidemiology of rheumatoid arthritis is sort of this bimodal where you have it in the 20s, 30s, and you also have it in 60s to 80s. So it's actually very common to be newly diagnosed later in age, right? It's not something you have to have when you're young or only when you're older. It's a very wide age group. And it may be that over that time where you're preclinical or don't have any symptoms, that you have the osteoarthritis in the background that's happening, which is totally okay. And it's also good to recognize what symptoms don't align with it. And that's where, and not that it can be challenging, because usually you'll know some of that there is an overlap, but usually if your knuckles are swollen, your wrists are swollen, you can't get out of your bed, it's more supportive. Again, those three symptoms, right? Those three questions that I asked earlier, they're good clues because osteoarthritis will be there, but then you notice a change and you can look at your hands to say, well, this is not fitting in with what I would expect or where I would expect the osteoarthritis to be. And these are new areas. Then you can say this is an overlap superimposed rheumatoid. So absolutely you can have both. And it's not like you're limited to one or the other. Usually you like to explain things under one umbrella, but it doesn't mean having a new rheumatoid doesn't mean all this time it wasn't an osteo the whole time. It may just be something on top of it.
All righty. So a question that I answered near the beginning, I'm going to reopen and then add on to it. So one of the attendees asked, what specialist should I go to? And my ingrained response is your primary care provider first, and they will make a referral to a specialist based on. So anyway, off of my primary care soapbox. Why do rheumatologists handle osteoporosis injections?
There's no limitation. You don't have to. Osteo, again, bone. porosis or penia, meaning less dense. And osteoporosis is actually, it's not osteoarthritis, right? So it's important to know because osteoporosis you don't feel. There's no pain in osteoarthritis. If you're saying I have pain everywhere, I have osteoporosis, unrelated. Osteoporosis is the density of the bone in the bone itself. Osteoarthritis are the ends of the bone. So the density of the bone, the biggest risk is age, and there's a lot of different factors that go into it, steroids and other medications. But in general, if you have osteoporosis and you have a higher risk for it, like for fractures and whatnot, you have oral options, you have sub-Q injections, and you have IV infusions. There's really no limit. It's not a sort of a specialty limited prescription or semi-limited treatment. If your primary care is comfortable, and a lot of places are, that's totally okay. You can schedule for injections, you can schedule for infusions. A lot of places just don't feel comfortable or they don't have the bandwidth or there's whatever reason, but it's not like you have to go to rheumatology for it. It's not a restricted thing. In fact, we're being grateful, not grateful, but I think we'd be supportive of the idea if primary care wants to do that. There's practitioners who just do, like rheumatologists who just do, metabolic bone disease. That's osteoporosis, and it is more complex than it sounds. There's a lot of research on osteoporosis as well, so there's a lot more to it than what meets the eye. So yes, there's more up and coming things, but in general, at least the beginning part, there's nothing limiting primary care or anything outside of rheumatology to do it.
All righty. Why do you feel better with activity and worse addressed with inflammatory type as well as what physiologically is going on in the body?
When you have swelling of the lining of the joint, you have the gelling phenomena. So gelling, as in, you can think of it in different ways, but if you have sedentary and not moving versus being active, if you have sort of this wear and tear, and one way to think of it, if you have bone spurs that are, if you have bone spurs anywhere else, you have a lot of area for growth. But in a joint is a very limited space, so you don't have a lot of growth. And if you do, it's hard to maneuver in that tight space. So if you're active, you can say that there's more strain and stress on the joint, which is why the more is pain more versus if you're swollen, and it helps alleviate some of that, the thickening, that stretch in the capsule, and it helps sort of keep things sort of, I don't want to say lubricated, but active in simple terms. So all the cytokines, all the inflammatory milieu that's there, that is activity is sort of helpful versus wear and tear, the more active, more sort of mechanical factor you want to call it there. So it's not, I don't want to go too deep into the whole micro or the immunology part of it, but in general terms, it's just from a structural perspective, it may be a clue that's very supportive. Not universal, but it's helpful.
All righty. Nicole, any questions from you?
Yeah, sorry, I hit the chat instead of my mute. We had a couple questions about pre-existing diseases like Hashimoto's, or if you already have pre-existing arthritis. Are you at increased risk of developing rheumatoid arthritis or other forms of autoimmune inflammatory diseases?
Usually say in general, like one autoimmune disease increases the risk for other autoimmune diseases, in general speaking. And Hashimoto's is one, it's a good example of another type. So Hashimoto's is immune response against your thyroid gland, but it's an activator. So technically that is an autoimmune disease, right? Auto meaning self, in this case, your thyroid gland, immune meaning your immune system attacking the thyroid gland. So autoimmune thyroid disease is just like autoimmune rheumatoid arthritis or autoimmune like multiple sclerosis or whatever. You can literally choose any protein of the body. And if you train your immune system to attack it, it's an autoimmune disease of that thing. Whether it's your nerves, your muscle, your eyes, your skin, your literally anything of the body that you're born with, you can react to. If you can make it, you can break it. So your immune system can be quite varied. And most time it's a very good balance. We take it for granted how lucky we are as humans to have a very robust immune system. And it is a remarkable thing, except when it doesn't, when it does things what it shouldn't be doing. So Hashimoto's is one, and it can give you false positive results. Like you probably, I think a good example here with the lupus test, the ANA test, the anti-nuclear antibodies, they're notoriously false positive in the public population. The population, like 10% of them false positive test. One of the contributing factors is if you have an autoimmune thyroid disease, your antibodies against the thyroid gland will cross-react and give you anti-nuclear antibodies. So it'll give you a sort of a, hey, you may have lupus, even though you don't, absolutely not. But
Yep, happened to me actually.
so that's where, so yes, it's possible to have one autoimmune disease that sort of goes, and the genetic plays come together. So if you have, for example, psoriasis, the psoriatic arthritis, the inflammatory bowel disease, the eye disease, the inflammation in the back tends to run together because of that HLA, the whole risk. So yes, there's a much more, slightly higher, not in everything, but in generally, if you have one autoimmune disease, it's a possibility that it can spill over or crossover based on genetic risk factors.
All righty. I'm going to ask another sort of or do a double question here. Um, so the first part is, what kind of activity can cause stress on the hands, bones? And along with that, why don't we hear more about people with arthritis in their jaw?
The TMJ or whatever, the TMJ arthritis, the temporomandibular joint arthritis, and activity in other areas. It's a great question that's why I said there's an overlap between wear and tear and autoimmune and inflammatory arthritis. It's not all wear and tear, because you might be wondering, well, why are my tips of my fingers stressed out? I'm not doing anything with them. Why are there bone spurs there? Why is there narrowing there? Am I doing, it's not like you were, doing this 100 times, for years and years. So there's some things that we don't understand. And I think that's where osteoarthritis is coming into play. It's not just wear and tear alone, and that's an oversimplification of it. So being sort of activity is one risk factor. And TMJ, you think of that, yes, it can be mechanical. It can be related to the use in some ways. So TMJ arthritis is common, but it's also common in autoimmune disease. So TMJ, just like the neck, it has a lining. It has a synovial lining. So the lining there can be inflamed. And we do see that in kids quite commonly, actually. If you have juvenile rheumatoid arthritis, when you're diagnosed younger in age and you have inflammation of the TMJ joint, it'll prevent it from growing. That's why they have smaller jaws as they grow, the micronathia. But it's a sign that they've had TMJ arthritis from the rheumatoid arthritis growing older. It's not as common as you get older as a symptom. It can be, absolutely, yes. But there's also a big overlap with the osteoarthritis. So as far as, why don't we hear more about, the activity causing osteoarthritis, and why do some people get it earlier than others? It's true, but if you have a family history in your immediate mom or dad with osteoarthritis at an early age, it's likely that you also get it at an earlier than age compared to someone who's older. So why is that the case? Why, if it's all wear and tear alone or nothing else, why are some people getting it at 50 as opposed to getting it at 80? I don't think we have all the answers about the osteoarthritis. It sounds simple, but it's highly elusive. Like, we can replace a joint, we can't regrow a joint. If you wear your cartilage out, there's no way to like inject it, stem cells, whatnot. It hasn't really been effective yet. So there's more to it than in medicine. We're still on that learning curve and researching a lot about the osteoarthritis.
Right, there's one company in particular whose name I will not mention, who touts in various injections as being the panacea that'll take care of all of this. You can avoid surgery, and so on. And it's interesting how well they sell the potential in the absence of clinical proof that it's efficacious. What causes nighttime swelling in the hands, in or outside of the presence of any kind of arthritis?
I think swelling in general is good to, I'll broaden that term because swelling can be used in many different contexts. Swelling is quite literally, you see swelling, it's a visual thing. It's also a palpable thing. And swelling can be in different layers. Going back to anatomy, you have skin, you have subcutaneous, like fat, subcutaneous tissues, you have muscle, and you have the joint capsule sort of thing, and you have bone at the very middle. So any one of those layers can be involved and give you swelling. When you think of swelling, location is important. If it's swelling of your ankles and legs at the end of the day, that's probably just edema or like the soft tissue swelling from either because of, blood pooling, the varicose veins, and both legs are swollen. You put your fingers on them, there's pits there. So that's swelling. That's leg swelling. That's ankle swelling. That's foot swelling, but not rheumatoid and not joint swelling. So joint swelling is different than swelling of the hand. And that's important because if your whole hand is swollen and it's puffy, is it skin swelling or is it underlying joint swelling? Because joint swelling is specific for arthritis. By definition, that is arthritis. Arthritis meaning swelling of the joint. But if the swelling is of the whole hand or the arm or between joints where there is no joint, then where's that swelling coming from? So that may be the skin, the muscle, that's a variable. So there's a lot of different causes, whether it be lymphedema, whether it be just something blocking it, whether it be blood clots. I won't put the thought that much in there, but again, different causes. So there's very different swelling can be variable, but not all swelling is joint swelling. And that's where the physical exam is important to tease apart what is what. And if it's
Right.
not swelling, it may not be arthritis.
And can just poor circulation cause swelling?
I think we tend to simplify it. So poor circulation is a different way of saying, like the varicose veins, or like, when you have at the end of the day, and that's a clue. If you have swelling at the end of the day, it's because you've been standing during the day, and it gets better in the morning because you've been lying in the morning and it has had time to sort of go back up. So that's the poor circulation is, you can define it different. Peripheral arterial disease, when you have arterial disease because of the narrowing of the blood pressure, the thickening of the linings, the calcium be high, if you had a history of strokes and heart attacks, yes, you can have poor circulation, but not all poor circulation will cause fluid to not be able to gain back. Because the swelling is not because there's more or limited blood flowing there. Swelling is because blood is not being drained back. So it's more of a venous and lymph drainage and vein drainage. And that's where people who have like, people usually are older who have multiple other risk factors. So including obesity and weight, with the high blood pressure, and of course, heart disease is a risk factor for it, but does not mean, so poor circulation is a very loose term. It's a very non-specific term. So technically, yes, a part of poor circulation, meaning poor drainage, not just poor circulation can be, but not usually the inflammatory type. So, and usually if you have inflammation, it tends to be like inflammatory inflammation, inflammatory arthritis, it tends to be more localized as opposed to like the whole arm, the whole hand. Yes, possible, but generally speaking, it should be something localizable.
I must compliment you. That's one of the most brilliant explanations and responses to that question I've ever heard. Nicole, over to you.
Is there a specific exposure that could cause RA? And could that apply for any autoimmune disease or just RA?
I think absolutely. I think there's so much interest that you can go into it. So if anyone's interested in immunology, there's a field is ripe for research. We think we know a lot, and when we do, we've come a long way. But there's an infinite amount of knowledge that's left. I think we need to humble ourselves and what is out there, which is why research is so important. And the U.S. is one of the great places that invests a lot in research infrastructure. So part of the activation of the immune response is immune activation. So technically, when you have, the question here was about infections, and absolutely any infections triggers, and even vaccines can trigger the immune response, and as such, it can become activated and sort of propagate. So those are, you can think of, one, the slide ahead, the post-translation modifications, or things that you're born with, but they change over time. One of the causes of that change can be things like infections, can be things like medications that you become allergic to, can be things like vaccinations, anything that really activates the immune response in the process of clearing that, whatever that is, that infection. And it can be cancer too, in the process of, like, if you have cancer for whatever cause and you're on treatment or you're clearing it, all that inflammation that is targeting there can affect the surrounding areas, which can affect and change what they look like, and over that can expose things that weren't previously exposed, hence the immune sort of response to that area. So then you can sort of, but it's not by itself, it's not alone. I think you have to have certain risk factors to get to that point. So not everyone with infection is going to get it. It's not like, everyone should be afraid of the flu or something, right? So it's not that all like COVID is, and we see cases all the time where you have autoimmune sort of cases almost correlated like a week or 2 weeks after a certain trigger. Not always the case. I don't want to overemphasize too much because it's not common, but it's possible.
All righty. Talking about gout for a minute. Can gout be in just one body part? And or what's the progression? Do you start experiencing it in one place and then in another and another and another, and maybe it resolves in original ones? Talk to us about that.
The oxygen tension tends to be, and the acidic environment tends to be most sort of the further away you are from the heart. So the feet, sort of where, your venous drainage is relatively, slightly less. So you normally think of podagra or the big toe inflammation sort of happening first with gout. So the uric acid, when it's too high, sort of speaking, hyperuricemia is different. High uric acid in the blood does not mean you have gout. I should put that out there. Just because your uric acid in blood, someone tested and it's like 9, doesn't mean you have gout, right? You have to have symptoms, just like the rheumatoid arthritis. Blood test does not mean disease. So it starts off usually in the toes. It can eventually ascend. Can it be limited? Absolutely. People can just have it in one area. The risk factors of which area, if there's a prior injury or if there's a prior area. So think of uric acid is normally flowing in the body, right? If you have a higher concentration, it's almost like if you have a rough patch it's more likely things will stick to that rough patch as opposed to the smooth areas. So if you have pre-existing osteoarthritis or arthritis in general, it's more likely that the gout crystals or two are going to accumulate and sort of stick and grow onto and become tophi in those areas. So normally you think of it as your great first big toes normally, and then it sort of ascends to the ankles and the knees. And then it can involve, gout is not limited to your feet and toes. It absolutely can involve the hands, wrist, elbows, basically any place. If you get long enough, progress enough, it'll be there. But can it be limited to one area? Some people just have it in one joint for the whole life, and that's fine, right? So monoarthritis means one joint. Monoarthritis meaning mono, one disease, one joint. And gout can present with monoarthritis and stay with monoarthritis. Oligoarthritis, oligo meaning few, few meaning like 2 to 4. So it can also be oligoarthritis, or it can be what we see as in rheumatoid is polyarthritis, poly meaning many joints. So it usually starts with monoarthritis, one joint, usually the toes, and then it can progress to become polyarthritis, but it doesn't have to. If your diet and if you're not doing a lot of red meat, if you're shellfish, seafood, any high purine diets, that's what, high when you're metabolizing the purine, that's what sort of converts to uric acid. So if that is sort of not, it's hard for me, easy for me to say, hard to do. We should really enjoy it, but that can be a trigger of a uric acid serum. And it's not just high uric acid that causes it, it's the fluctuations. It's almost like a stroke. You don't just get a stroke from high blood pressure. You go from a high to a low to high. It's that loss of sort of that balance, that homeostasis that causes a stroke. Gout is the same way. It's not just having high uric acid, it's going from high to low and low to high that causes the triggers. That's why diet can cause it. If you start treatment for gout without a prophylaxis, you can ironically cause a flare because of that levels.
Right. So, Doctor, do you see the Q&A icon at the bottom of your window? Can you click that there? The number 32 should be next to it. And those are other questions that have come in since your presentation stopped. Rather than me and Nicole asking them, these seem to fall into some fairly easy groups. And perhaps you could just sort of tackle them, and we will mark them as answered live as you go through them.
Absolutely. I'll do my best to go through all of them. So I'm going to go in order. Does ultrasound show, what does the ultrasound show that the X-ray cannot? Ultrasound X-ray shows bone. Ultrasound also shows cartilage, the lining of the joint and the synovial lining, tendons and ligaments that the X-ray cannot. Is it ever too late to treat rheumatoid RA? It's never too late. I think that's why even if you're, 100, we still patients, quality of life matters. And that's what our goal is. Our goal is to treat for two goals, preserve function and to prevent damage. So it's never too late. Does RA and OA have a permanent cure? Excellent questions. We have great treatments for arthritis. We are not at the phase of cures yet. I think that'll be a few generations and lifetimes from us, but our goal is going to be with treatment, with cure. I think that's where genetic therapy is going to come in. So we have great treatments that are good enough to the point that you don't feel, and the prognosis is excellent. If you have RA, you'll live just as long and just as well as someone who doesn't, but not in the cure phase yet. But we hope to get there. How common is RA or OA in teens? OA is not common in teens. RA can be common in teens, but OA, I would be very cautious to diagnose that in someone who's younger than like 50 or at least less than 30, unless they're someone who's very, very physically active. Can RA lead to tears and ligaments and tendons? It can cause the inflammation, the lining of the synovial lining, because the capsule is right beside the tendons, ligaments. So absolutely. In fact, that's one of the things you want to avoid, especially in the neck because of all the ligaments there. So it can absolutely lead to tears and ligaments and tendons. What are some ways you can treat both rheumatoid and osteoarthritis? Cannot be mitigated or cured. I think the best thing is going to be physical activity. If you have strong, stable joints, at least you can mitigate some of that complications and don't be afraid of activity. It's fine. You do not need to suppress the immune system absolutely not an osteo, and even rheumatoid. If you have nothing else, just over-the-counter anti-inflammatories, ibuprofen, naproxen, Celebrex, Mobic. These are good first line as long as you don't have heart disease or have ulcers in your stomach. If some person suspects they may have gout, what would they seek treatment from a rheumatologist, a primary care, or an orthopedist? Usually gout is not rheumatology specific. It most commonly is primary care, but it can be seen by rheumatology at the request if there's something that come up. One thing to note, if you have kidney disease, that does not mean you cannot use treatment for gout. It's not a thing. So you can use allopurinol even if you have kidney disease, even if it's high. There's no limit on that. Is it possible to get arthritis in your spine? The degenerative osteoarthritis, yes, and inflammatory arthritis. So there's a very specific category of inflammation just in the spine. Spondyloarthritis, spondy means spine. So there's the whole big category. So absolutely. They can both, most commonly it's non-inflammatory, but we are biased. We see a lot of inflammation in the spine, usually in the pelvis, the sacroiliac joint. We start first before it goes up. Do the antibodies have a specific resistance with respect to OA and RA? Um, I'm not sure what resistance means. If I were to say, is it predictive? Yes. If you have positive antibodies, it's predictive of more severe disease. And that can mean that you may be more resistant to treatment and may require more aggressive treatment. And there's more risk for erosions. What would you consider the criteria for diagnosing anti-cardiolipin antibody antiphospholipid syndrome? Antiphospholipid antibodies are antibodies against antiphospholipids that are part of the lining of sort of the arteries and veins in your blood vessels. So they are criteria is based on blood clots, miscarriages, or positive blood tests. The more you have, the more likely, but you should have at least two of those. So the criteria at least has to be either multiple miscarriages or multiple blood clots that are unexplained, along with the presence of these antibodies. And if you have one of those two clotting episodes with the blood test, then you can support it. But the blood test should be repeated twice, at least 3 months apart, to make sure they're not false positive. Can avascular necrosis found on MRI be caused by autoimmune related disease? If so, what could the mechanism of action be that leads to AVN? Yes, I think so. And we don't see it much common in rheumatoid arthritis. We see much common more in lupus and other types of arthritis, especially if they've been treated for steroids for a long time. So more along the others, like the lupus-related connective disease, yes. And that mechanism is thought to be various steroids, and there's been a lot of research as to why it happens, whether it's because of the expansion of the bone marrow and the fat area is compressing it. Is it just because of the blood flow being less? But it's variable. Is it part of complication of treatment or as a blood clots even? Antiphospholipid antibody. We just talked about that as one. When do you treat RA with biologics? Usually now you have a much lower threshold. You can treat biologics in RA, and you can start with them actually for all you need. There's really no limit. The guidelines are very clear on what works most. You usually start with the non-biologic first, because many people will do well on those alone. But if there's if evaluate every 3 months, if there's not a good response, you're so swollen, you're so stiff, you can't move, and your disease activity index, whatever you're doing is high, you transition over. There's a lot of options, no limit. You can do it as early as your first one or fifth one. The reference to the three, that one went away. In reference to the three easy questions, but the second swelling, what do you do if you have one? So I think the question here is if you have one swelling but not stiff or you're not limited, if one of the three, what do you do? And it may be early on. I think the best thing there is just monitor and be evaluated, because that's a part of the piece. But that's when you would say the pretest probability is in the middle. That's where the blood test, imaging, and your history and physical are important, because that tips you over. Is this an early something, or is this something that's going to become more? Can arthritis be an underlying cause of life-threatening condition or disease? There's luckily in rheumatology, there's not a lot of life-threatening diseases. We're fortunate in that there are a few, there are a handful that are. Rheumatoid arthritis, if it's life-threatening, is if it affects the neck. We don't see that anymore. It can also affect the lungs, where it causes sickening and hard to breathe. Happens over decades. We have antiphospholipid antibody. We just talked about it. If you have catastrophic APS, where it's like clots everywhere. That's one. Affecting the kidneys. If you have like severe inflammation in the kidneys, can happen. So, and especially with the lungs, if you have like trouble with the airway. So there's a lot of yes, life-threatening diseases, but thankfully in rheumatology, they're not common, and not as much as they used, but we still absolutely, yes, they exist. When you have an injury, what are you prone to have arthritis in? Why are you prone to have arthritis in that area? Arthritis, it just means, I guess, I'm assuming this means non-inflammatory arthritis, which is the wear and tear. And part of that reason because of the healing response. So if you have an injury, a fracture, or as I say, you had that bone as it's part of its recovery mechanism can affect the ligaments, which don't heal as well. And once you have bone changes or bone spurs, they don't go away. You can't really like shave off bone spurs. I mean, you technically could, yeah, but they tend to grow back. And that just is more like a structural limitations to have over time. It's almost like patients who are hypermobile. It's not an early thing, but if you're in hypermobility with more of instability, over time it adds up. So how you're prone to arthritis, it takes like years to decades, but it's possible. Is arthritis hereditary? The answer is yes, to some degree, but not really, because there's many people without it that have it. So, and many people who have the genetic modification or have the genetic mutations don't actually end up getting it. So genetics is a big part of it, but not the only part. So the answer is yes, it's hereditary, but even if you have a strong family history, doesn't mean you're going to get it. Osteoarthritis is the same way. It's not just inflammatory. Even if osteoarthritis, if you have family history, you can get it earlier than age, but doesn't mean you have to. Catching up with what Rimmer said, does it mean that RA can occur at any time in our lifespan and is more commonly seen in 20 years? And it's true. It's more generally, it's not as common. Like there's a big curves that you can look online, but generally it's not like you can be as early as months old or in 90s. So it's not age restricted disease. If a person on dialysis, can this osteoporosis affect the bones? I'm guessing if the question is about can you get osteoporosis from dialysis? Yes, but it's a different type. It's a different type of like renal osteodystrophy. That's a complicated question because we still are trying to figure out the answer to that. It's complicated, but the answer is yes, you can get osteoporosis if you're on dialysis. Whether to treat it or not is a team decision. In general, is RA or OA more severe, or does it depend on just how bad the case is? I think it's more of the case dependent because you could just have pain in one finger, and if it's the most severe pain that doesn't go away just part of everything, it's the worst thing in your life. So it's more of individual and things. It's not like one disease is worse or better than the other. We are fortunate we can treat rheumatoid arthritis pretty well to the point that you probably can't even feel it. And do live your whole life without having flares or deformities, versus OA, which has no organ involvement. There's no risk for heart, lung, liver, kidney involvement. But if you have pain that's limiting your quality of life, it can severe. So it depends on what you call severe, but generally it doesn't, disease specific doesn't make a difference. Are infusions a common therapy, right? Yeah. Autoimmune diseases are not just rheumatoid, but anyone's biologics, which come in infusions, they are very commonly used for RA. If you have RA, are the calcium depositor, how would you have osteoporosis? So if you have RA, and are a calcium depositor, how would you also? Okay, I think the question is asking osteoporosis. There's an increased risk for osteoporosis in rheumatoid arthritis. If you have inflammation, then the active immune response on top of the joint can erode the bone underlying it, and sort of if it goes uncontrolled, it'll sort of I guess decrease the bone density, especially area around that joint area. And so rheumatoid arthritis is one risk factor for osteoporosis. A big one actually. Why does it seem to take years why does it take years and can you find autoimmune disease such as, okay, the question is asking why can it take long to have a diagnosis? Two parts. One is symptoms may not all be apparent at the same time. So when you have the diagnostic or classification criteria, they're looking at all the criteria, but not everybody presents like a textbook with all the criteria at the same time. They can be spread over time. That's one reason. B, I think who you see matters. Like having a good primary care is very important to identify and know what the risk is. Sometimes it is a function of having the tests that come up in the right way. It can be elusive. So in early cases, when it's undifferentiated, it can be harder because the symptoms can be one of many things. And if there's no evidence of active damage or active disease, you may not be inclined to treat it, and the non-inflammatory symptoms may be more predominant. It's a complex question, but that's my attempt at simply quickly, I guess, answering it. With degenerative osteoarthritis, if doing exercise is helping, why does it continue to get worse with age? Exercise is helpful for joint stability and protective in some ways. It's almost like doing your own brace. So sarcopenia is a very good prognostic factor for mortality, actually. So it's good to have good muscle bulk in general, not only because it stabilizes joints, but getting worse with age, that's a good question about why does osteoporosis or osteoarthritis, excuse me, why does osteoarthritis happen anyway? Why do humans have it at all, I don't know. I think medicine is trying to figure out why it happens and how we can sort of prevent it from happening. Do you get any joint swelling from knee problems or conditions such as patellotendinitis, patellofemoral pain, or things like this? So do you get any joint swelling from, I think yes. So non-inflammatory causes like tendinitis or tendinitis technically is inflammatory, so tendinosis or any mechanical things definitely can give you joint swelling, like plica, anything like that will give you swelling. And in the beginning, you don't know, is it rheumatoid or is it something non-inflammatory? That's a good thing to look out for. And if you have psoriasis, does that mean you can or will you get psoriatic arthritis? How is the same or different from gouty arthritis? Psoriasis, a third of patients will have psoriasis first. A third of patients will have the arthritis first. Other third will have both at the same time. So, and that gap can be years and decades. So if you have psoriasis, it does not mean you're going to have psoriatic arthritis. It may mean that 20, 30 years from now you develop it, sometimes not at all, but it's there. How is it different from gouty arthritis? Gout is usually limited local to one area, but not always. In psoriatic arthritis, it can be in the back or in the hands. But psoriatic arthritis has a very different distribution than the gout. So usually you can tell by symptoms, but can you get it? And will you get it? you don't have to get it, but there's a risk that you will, and that's a function of sometimes time. But a third of patients will often develop the arthritis after the initial episode of psoriasis. Is it recommended to take supplements for joint health? If I get into this, I mean, there's such a variety of evidence behind it. Um, I'm going to hold my opinion on that, and I'll say I'm not opposed to supplements. Glucosamine, concoitin have been shown, and there's a lot of different supplements. In general, I'll say it's not going to harm you. Is it going to help you? It's up for debate. I'm inclined to say personal opinion, not needed. Um, but I'll leave it to you to say whether it's helpful. It's not going to harm you whether you do. What are the types of arthritis cause subluxation shoulder and locked joint feeling? I think that can be both. It doesn't have to be. A lot of times, if you have hypermobile joints, subluxation is easy. Rheumatoid can affect shoulder and osters. So technically, locked joint feeling, and if you just don't move your shoulder at all, like the frozen shoulder will give you a locked joint too. Diabetes are a higher risk for doing that. So it can be actually all of the above. Can having spinal injury, such as microdiscectomy or spinal fusion, increase your risk for developing arthritis? Sort of the opposite. I think the arthritis has led to that. I won't say that. The answer may be yes. Spinal fusion and microdiscectomy, yes and no. I think it's more independent. It's more of a practical. We know that patients who get partial knee surgeries are at high risk for osteoarthritis. Um, I'll say I'll pass on that one. I don't know enough evidence on the orthopedic world to safely and reliably give you an opinion. But my personal opinion would be that not necessarily, but possible. What about uterine inflammation? What seed can one do? What about uterine inflammation? Not common. Uterine inflammation is not common. I don't think that's a part of rheumatoid arthritis per se. Um, not, I mean, it can be part of antiphospholate and different things, but I think uterine inflammation, I'm assuming that means like fibroids and things, not usually related with the rheumatoid part. I mean, it may be exceptions to that here and there as a systemic thing, but not as a isolated thing. If arthritis is genetic, can it be prevented or stopped early on? That's the question of the century. Is it? I think it's a double-edged sword, because if you do have a way of stopping early on, does that mean you should do it? Should we do genetic therapy if you have the option to do it? There's a whole ethics question behind it. As of now, we don't have a way of preventing it. We have a way of measuring it early, finding it early, but not preventing it in the preclinical things. There's no way to, like, if you have no symptoms at all, if you're like, let's say 10, 15, 20 years old, and you may be able to get it, does that mean you should treat it now? Studies have shown that it doesn't make an outcome difference. Not what we have currently. How can RA or OA affect any sports player with running? There is a lot of research whether OA causes more early knee osteoarthritis, and the answer has been mixed, but generally speaking, no. You don't have to limit your activities if you have RA or OA. And generally speaking, you can be as active as you need to be within your own physical comfort and limitations. So generally, it can, but not necessarily. I think a lot of research has shown that it's better to be active, and it shouldn't be a worrying about for early osteoarthritis. And RA is not generally associated with activity or sports in general. What OA treatment could you offer for patients with CKD? You can't do NSAIDs. Duloxetine or Cymbalta is fine to try here and there, not sponsored. But I think a lot of this is just going to be conservative with acetaminophen and mostly just therapy, physicals. The more strengthened, the stronger your tendons, your muscles, the more stable the joint and more likely is there. It's a tough question because medicine hasn't really advanced for osteoarthritis. I wish we would, and there's a lot of work, but we haven't reached there yet. Is neuropathy related to OA or RA? Not necessarily either. I think rheumatoid arthritis can cause inflammation of the nerves, and neuropathic vasculitis is common. So, but OA can cause nerve sensitivity. You can get a lot of nerve sensitivity with it. A lot of patients with, like, I guess, secondary fibromyalgia, you want to call it that. But if you had to choose, the neuropathy can be part of rheumatoid, but not as common anymore. Neuritis is not as common. It's rare, but it still happens. If a person under 45 begins experiencing arthritis in multiple joints that requires joint replacement, could that be caused by an autoimmune issue or another underlying issue? It is still common. It's not, being less than 45 doesn't rule out osteoarthritis. And especially if you have a strong, like a mechanical, or not just center, but if it's clearly, if you see osteoarthritis and the indications for surgery are actually not imaging. The indication for joint replacement is A, if you have pain that's not getting better with, or basically intractable pain with not better with conservative management, and B, loss of function. So if you have loss of function, you can't do the activities, and you have intractable pain, those two are good indications that you may need to proceed with surgery. You don't want to start with surgery unless your last resort, but It does not mean you have to, if you get to that point, the surgery is not unreasonable, but you would still want to make sure it's not an inflammatory type, and you want to control that first so that it's not contributing to the joint symptoms later on, or even contributing to the, and maybe sometimes you can prove it, your symptoms get better, that means you can hold off on it. But if you're thinking surgery because of the osteoarthritis, you should have clear evidence of osteoarthritis on some imaging or some objective finding. But the two reasons are not imaging. If you have loss of function or intractable pain. What are the differences? What are the different characteristics between dermatomyositis, Sjogren's, and RA? Dermato meaning skin, myo meaning muscle, eye meaning inflammation. So dermatomyositis causes usually shoulders and hips weakness, and pain. Sjogren's causes sort of this non-inflammatory arthritis, I mean, sort of this weird arthritis. It can be inflammatory, almost like rheumatoid. So RA and Sjogren's have an overlap. They can cause inflammation that something looks similar. Dermatomyositis can also have arthritis in a different way. So I think there's a lot of different system involvement that is different. Sjogren's is more dryness, RA is more of like joints, and Sjogren's can be other nerve and stuff. Dermatomyositis is usually muscle and skin, but the arthritis can be truly, in a quick word, similar. So they all can have inflammatory arthritis, but they look slightly different. But in general, if they're all the inflammatory type. Can ESR and CRP blood test results be affected by taking anti-inflammatory drugs like naproxen in the day or prior to having these blood tests drawn? I would like to say I don't have clear evidence. I don't know of studies that actually tested that, but if I had to give an opinion, I would probably say not necessarily. Of course, if you're on prednisone or corticosteroids, of course you're gonna have a much more rate of false negatives. But the non-steroidal anti-inflammatories, if you have ESR is not as quick and CRP is not. I don't think it's going to dramatically skew the results to the point that you have to hold it the day of. If they're high, it's not going to go from like 50 to 0 or 50 to whatever, high to low in that small frame. So I don't think you shouldn't have to decide based or hold something like naproxen for that reason. Can you speak about lupus, hereditary, how to diagnose? Lupus is based off symptoms for the most part. I think one thing I'll mention this is that the ANA blood test, it's a very mixed bag because a lot of providers order it and it does not need to be ordered. A lot of tests come back positive and they don't need to be positive. But generally speaking, that anti-nuclear antibody or that ANA test, if it's negative, it's very helpful and you can just put lupus off the table, systemic lupus off the table. And the cutaneous lupus or skin lupus is still a possibility with a negative blood test. That's where skin biopsy is helpful. But if you have a negative ANA, you can just put lupus aside, at least for the time being. But the symptoms generally are what organ involvement. If you have low blood counts, if you have kidney protein or blood, if you have any trouble with the skin, with the butterfly rash, and if you have like the ulcers, and the joints are a part of it. Lupus does have arthritis component to it. And you add all that up and you do the specific antibodies. If they're positive, then you can say, okay, this is related to lupus. But lupus is such a broad heterogeneous disease because everyone may be different, which is why you cannot generalize lupus in one person to another. And then part of that reason is why it can be initially hard to diagnose because it may not be your case. But those with systemic lupus that is very active, it is very clear. You cannot miss it. The blood counts, all the labs will be sort of pointing in the same direction, along with symptoms too. What medication are best for treatment? I'm assuming that means for lupus. It depends on organ involvement. There's a very big wide variety. And in general, as a general rule for any autoimmune disease, you treat to target, whatever that target is. And usually the target is remission or low disease activity. And that in systemic diseases, your target is to make sure there's no active disease and organ involvement. So you're targeting whatever inflammation may be active. If it's in the lungs, it's different. If it's in the kidneys, it's different. If it's in the joints or skin, it's different. So it really depends on, it's a broad question, but the treatment is geared towards whatever, wherever or which organ is the most active. I think I don't see any more questions.
Yeah, that was the last one. You really flew through them.
Yeah, you can contact me if you need. Yes.
So for those of you who have asked if you can contact Dr. Verma after the session, please email me and I will forward your request to him. We've gotten, as you've probably been able to see in the Q&A, just scores of people saying how great the presentation was. And I've gotten many emails also. So to say that up until a couple of minutes ago, we still had 250 people here, a half an hour later than people normally stay. So you definitely hit a chord. It was fantastic. Everyone next week, oncology, thoracic surgery, and robotic surgery presented by Brian Nam, who's a thoracic surgeon with Christiana Care. Thank you all for attending. Dr. Verma, again, thank you very much. Good evening, everyone.